Good afternoon. Moving on to the next session, that is session 5, I would invite Dr. Mandeep Bedi and Dr. Moitri Shah to be the chairpersons of this session. The first talk, Reducing Lab Errors with the Aid of Technology, is by Dr. Atrayee Roy Chaudhuri. Please welcome Dr. Roy Chaudhuri on stage.
Good afternoon, everybody. First of all, I'd like to thank CAPCON, the organizing committee, and Quidel Ortho for giving me this platform to deliver my talk. So today, my topic is a bit different from today's theme of immunology, but nonetheless is very much relevant. So my topic today is reducing lab errors with the aid of technology. Over 60% of the decisions taken in patient care can be accredited to the findings of lab tests. Communicating the findings in a meaningful way is the primary role of a medical lab, that is, to provide vital information on disease diagnosis and management through appropriate lab investigations. Effective patient care can be assured only through quality diagnosis in each and every step. The piece of innovation in medical science is accelerating, but are the labs ready to keep up with the rapid transformation? Perhaps no. Hence, the need of the hour is digitally empowering the labs and using state-of-the-art research to make them globally connected powerhouses capable of breakthrough innovations at a large scale. So what are the technical tools that are at our disposal? How well do we know our sample quality? The usual suspects that cause maximum pre-analytical errors are because of interference due to presence of hemolysis, icterus, and turbidity in the samples. So first, hemolysis. A study by Omar et al. Shows that although the general incidence of hemolyzed samples in clinical lab differs broadly according to the clinical settings, geographical area, and facility type, the prevalence of hemolytic specimens can be as high as 3.3% in all of the routine samples. Next is icteric sample. Another study shows that specimen icteric index exceeding pack insert icteric index threshold occurs in 0.14% of clinical chemistry assays. The next one is turbidity. According to a Spanish study, the frequency of lipemic samples is 0.5 to 2.5%, depending on the characteristic of the hospital and IPD-OPD ratio. So what are the technology at our disposal? The measurement of sample integrity on a clinical lab system may help to avoid misleading results. There are multiple analyzers which offer this feature. Clearly, there seems to be some evidence that visual assessment of endogenous interference may not be accurate. Hence, automated instrumental indices are available on many different chemistry systems, but they are not always used due to practical drawbacks. Vitros microsensor technology is one such technology. It is an integrated feature in the Vitros analyzers that perform automated sample integrity index determinations. It is designed to assist lab personnel in assessing the suitability of patient samples for chemical analysis. Automatically, it determines the sample interference levels, indicating when these exceed analyte-specific threshold limits and flag results. So this is the technology that is at our disposal. At first, light is collected from the reflectometer lamp. Then it is transmitted through the patient sample. Then the spectrum of transmitted light is measured, and the absorbance is communicated of the spectrum. And finally, it is converted to semi-quantitative index values. The availability of an onboard feature for determination of the sample quality indices provides an acceptable option for appropriately assisting the interpretation of the impact of hemolysis, icterus, and turbidity on affected patient samples, leading to improvement in the accuracy of patient results. In conclusion, any chemistry system equipped with sample integrity detection module will provide the lab with a fast, standardized, economical, and automated means of assisting the technologist in the assessment of specimen quality by flagging assay results which may be compromised due to the presence, again, of hemolysis, icterus, and turbidity. So what are the pre- and post-analytical errors? The villain in clinical laboratory that can affect the results are broadly classified into 3 categories, as we all know: pre-analytical errors, analytical errors, and post-analytical errors. So pre-analytical errors, again, as we all know, are the errors that can occur from the time of sample collection till the analysis. Analytical errors are the errors that occur during the test procedure, and post-analytical errors are obviously errors occurring after the test has been performed. In a publication in the North American Journal of Medical Sciences show that 65% of the errors are due to errors occurring in the pre-analytical phase, whereas 23% and 11.6% are respectively related to analytical and post-analytical errors. So these are the different subtypes of error that are related to manual entry. I'll not go into the details. Now coming to the LIS system, which is the top mandate for a lab. The lab information system was designed as a turnkey system. The main functions are operated interactively on a mini computer, giving the lab complete control over daily processing. Collection of results from automated analyzers is accomplished via a microcomputer or microprocessor network. Links are provided with a central mainframe computer for immediate patient identification and historical data processing. LIS is designed to manage all the operations involving lab activities. The system has 14 major functions, including registration of test requests, production of specimen collection sheet, identification labels, confirmation of specimen collection, production of Ellicott labels, workload inquiry, production of worksheets, manual entry of test results, automated entry of test results, result inquiry, preliminary report, final report, daily activities report, including QC specifications, statistical reports, billing, etc. System security is provided along 3 directions: data entry validation, system access control, and memory protection. The main advantages of having an LIS are reduced clerical error, reduced clerical work, better evaluation of workload, faster communication, improvement of information given to the clinicians, adopted reference values, interpretation, comments, improved retrieval of operation, and faster billing, and effectively decreasing the TAT. So these are the advantages of LIS. It's a paperless solution, easy to handle, clear operation analysis, electronic notification facility, error-free process, seamless sample management cycle, end-to-end information tracking, and quick report delivery. So how intelligent is our report? What if the report comes with a panache? IntelliCheck technology is a series of unique and patented technologies providing integrated process control that performs, monitors, and verifies diagnostic checks through sample and assay processing. IntelliCheck technology that verifies analytical performance and reduces potential errors by providing real-time operator notification and tracking without additional reagents or sample volume, with no impact on the TAT and cost. The capability reduces the time, labor, and error potential of manual interpretation. So this is the screenshot from a module of Vitros, and the result review by IntelliReport occurs via different modules. These are sample metering, sample indices, reagent, sample plus reagent, that is the reaction chamber, luminometer, well-wash verification, and signal reagent. According to recent publications on lab performance in proficiency testing, erroneous results caused by sample mishandling or instrument malfunctions continue at high levels. In response to this, Ortho has made it a priority to address laboratorian concerns about result integrity with product enhancement to improve sample and reagent process control. IntelliCheck is specifically designed to establish confidence in results at every sample and assay processing step. A number of new patented processes have been combined with other Vitros technologies, such as smart metering and save the sample clot detection, to optimize performance and deliver a level of result integrity which was not previously attainable. IntelliCheck Intelligent Process Control provides full monitoring and operator feedback for specimen processing, reagent processing, and result integrity. Specimen processing begins with Vitros patented smart metering technology, which integrates several key elements that ensure sample integrity and optimize sampling performances. Automated sample status check performed during sample aspirations and dispensing use a pressure transducer. Anomalies or exceptions to expected parameters that may impact the quality of an assay result are identified and immediately reported. These anomalies include bubble detection, short sample detection, that is QNS, high viscosity sample detection that can occur in case of lipemia or presence of paraproteins, and clot detection. There is also a save the sample feature that returns the sample to the original container after a clot is detected. That is, sample is not unnecessarily wasted. Disposable probe tips eliminate carryover contamination concerns, which may affect results in systems with fixed probe diagnosis. Automatic sample dilutions are verified by measuring sample and diluent volumes in the reaction well. Result integrity is ensured by confirming the proper dilution factor was performed as requested. Reagent processing and signal reagent dispensing into the reaction well are critical steps in achieving quality test result from an enhanced chemiluminescent reactions, which is again very important for measurement of different immunoassay parameters. Using level sensing technology, elements of the subsystem which perform aspiration and dispensing of the reagents are verified. The reagent metering subsystem performance is monitored to ensure proper pump operation or also to detect obstructions in the probe, tubing or valve. Any detected exception or error condition with the potential to affect result integrity is immediately recognized by the error recovery software, and the operator is notified both visually as well as audibly. An automatic analysis determines the next process required for error resolution and if sample and assay processing can proceed. For example, if IntelliCheck detects a bubble in a particular sample, only the affected assay would be noted with a flag and processing would continue for other samples awaiting the processing. If all processing is paused due to a system error, it can automatically be resumed without operator intervention or loss of sample programming once the error condition has been resolved. So to minimize waste and cost, reagents are only dispensed when integrity checks are complete. So these are the advantages of having a dry chemistry analyzer in our lab. No reagent preparation required, no water drains, minimizes interfering substances, wide dynamic ranges, 6 monthly calibration, minimal storage requirements, long shelf life, minimal waste, and no MSDS required. These are the layers present in the microslide system. This is the upper slide mount, followed by a spreading layer of titanium dioxide, a masking layer, reagent layer, support layer, and finally the lower slide mount. And this is a picture of the spreading layer that holds back or traps the selected interference, followed by the reagent layer. Elimination of common interference is a major advantage. In dry slide technology, multi-layered reagents are applied to a clear polyester support base cut to the size of a postage stamp. That is a very small size. The spreading layer is a porous capillary network allowing the liquid in the specimen to penetrate through the other layers. Its porous capillary network assures uniform distribution of the sample volume over the slide area. The structure of the spreading layer traps large molecules such as lipids, proteins, and hemoglobin. This eliminates interference from these substances and creates a type of protein-free filtrate. In some of the reagents, there are special purpose layers added before the reagent layer which act as an added layer of filter for known interference to these parameters. For example, low pH buffer is present in glucose slides that reduces fluoride interference because glucose is collected in fluoride vials. The masking layer and in unconjugate and conjugate bilirubin slides screen out many color pigments like hemoglobin, carotenoid, and lipids. The scavenger layers of ascorbic acid in triglyceride slide removes ascorbic acid from samples, which is important in patients having vitamin C supplements or having lots of citrus fruits. Calcium chelator in the same triglyceride slides remove any calcium interference. Again, another important advantage is elimination of paraproteins. Paraproteins are monoclonal immunoglobulins or its components produced by the clonal proliferation of plasma cells or other cells of B cell lineage. As paraproteins are of large molecular weight, hence they can cause interference in various assays. So these paraproteins are trapped in the layer and it prevents their interference in the further assays. Dry chemistry analyzers like Vitros with methods based on reagent containing slides are shown to react after activation by the liquids in the sample measure of the concentration in a protein-free filtrate. Interference by large molecules like proteins and effects of volume displacement would hence be eliminated, which has been shown in multiple publications. Monoclonal proteins including IgG, A, and M interfere with estimation of various analytes like bilirubin, ferritin, calcium, glucose, uric acid, albumin, etc., leading to spurious results. And the final one is remote monitoring, which is again an advantage. There is a technology called e-connectivity technology, which is present in Vitros analyzers. It increases uptime, leads to faster resolution of any breakdown call, allows inventory management, and also there are time-saving updates and all these features with a commitment to cybersecurity. Hence, e-connectivity through remote access is a great way of increasing machine uptime and decreasing downtime. So that's all from me today. Thank you. And if anybody has any question, welcome.
Thank you.
I request Dr. Moitri and Dr. Mandeep to please felicitate Dr. Atrayee. Thank you very much for a wonderful and illuminating talk. Felicitations, please. Thank you, Dr. Mandeep. We will now call our next.
We would now request Ma'am Teressa Biswas to please come on stage for the next talk. The next topic is the diagnostic algorithms of connective tissue disorders by Ma'am Teressa. Ma'am Teressa is a co-founder, laboratory director and consultant biochemist of Bioscan Diagnostics and has come all the way from Guwahati to be with us today. Thank you so much, ma'am.
So, good evening, all the esteemed guests. At the outset, I thank the organizers of CapCon 2024 for giving me this opportunity to share my views on the diagnostic algorithm of connective tissue disorders. So, the term connective tissue disease, it refers to a group of similar yet different autoimmune multisystem rheumatic disease common in women and characterized by the presence of anti-nuclear antibody that can affect tissues and organs throughout the body. So while different authors use the term differently, some include rheumatoid arthritis, vasculitis, and myositis also under this umbrella, but most of the experts, they include only these 4 diseases under this spectrum, that is the SLE, the Sjogren's, the systemic sclerosis, and undifferentiated connective tissue disease, and mixed connective tissue disease. Now, SLE is the flagship of connective tissue disease, while because it is most widely studied, but nevertheless, Sjogren's is not far behind, but it is more common than lupus, but it goes unrecognized. Now, the concept of the connective tissue disorders, it came way back in 1941 from Paul Klemperer and his colleagues at the Mount Sinai School of Medicine in New York, which first proposed the concept of collagen vascular diseases. So as it became apparent that collagen is but one component of connective tissue, the term connective tissue disease gained widespread acceptance and persists till date. So the laboratory testing for the anti-nuclear antibodies and the specific autoantibodies associated with the presence of the systemic autoimmune rheumatic diseases is useful in the evaluation of these diseases. Now, from a clinical standpoint, 4 questions need to be addressed. First, when to suspect the connective tissue disease? What is the type of connective tissue disease? How to investigate a patient with connective tissue disease? And finally, how to treat this patient? So the clinical recognition of this CTD requires a high clinical suspicion because of the heterogeneity of the presentation and multiplicity of the organs involved like skin, mucous membrane, joints, lungs, kidneys, etc. So one should suspect the connective tissue diseases in the following situations, especially with multi-system involvement, especially in young women, inflammatory polyarthritis with additional features like fever, prominent mucocutaneous involvement, active urine sediment, cytopenias, neuropsychiatric features, fever of unknown origin, unexplained renal failure, polycerocytis, psychosis in young female, picture of an ITP with splenomegaly, Raynaud's phenomenon, palpable purpur, and the list goes on. So despite these myriads of presentation, patterns are often recognizable and they can be diagnosed. Now, I'll be talking on these 4 spectrum of the systemic autoimmune rheumatic diseases. So coming to the presentation of systemic lupus erythematosus, so a young female with alopecia, photosensitive malar rash, presenting with these clinical domains with a positive ANA, particularly homogeneous pattern or a speckled pattern at an initial dilution of minimum 1:80 on HEP2 cells, will be diagnosed as SLE. So these are the features of the SLE with clinical domains, mainly fever, the cutaneous domain with alopecia or oral ulcers, with arthritis, synovitis or morning stiffness present, with psychosis or seizure present, serositis, and with hematological domain where there is leukopenia, thrombocytopenia, autoimmune hemolysis, with renal involvement where there is proteinuria of more than 500 milligram per 24 hours, where with the immunologic domain where antiphospholipid antibody is more than 40 GPL, that is the cutoff, and where there is low complement proteins, that is C3 and C4, and also very presence of anti-dsDNA or anti-Smith antibody. So a patient needs to score at least 10 points to be labeled as SLE. Now coming to the systemic sclerosis, the same features with the same clinical context, if there is Raynaud's syndrome or thickening, skin thickening, then it can be with the presence of anti-centromere antibody or anti-topoisomerase 1 or RNA polymerase 3, then it can be labeled as systemic sclerosis. So the systemic sclerosis can be localized or generalized. Now coming to the generalized one, if it is limited cutaneous, then the anti-centromere antibody CNP B will be present in 60 to 80% of patients. If it is diffuse, then anti-topoisomerase antibody or SCL70 will be present, or RNA polymerase 3 may be present in 4 to 25% of patients. If it is scleroderma, same SCL70 will be present with anti-centromere CNP B, A or B, and if it is an overlap, there will be the presence of U1 RNP present. So similarly, a patient presenting with Zika symptoms like dry mouth and dry eyes with RO SSA present in 70 to 80% and La SSB autoantibody present in 30-40% patients with elevated ESR, CRP and anemia of chronic inflammation. Urine analysis may show mild proteinuria and white cell cast, then this will be labeled as a Sjogren syndrome. And in a few cases where the symptoms appear to be very similar to connective tissue disease, but we cannot prognosticate or we cannot just classify under a definite phenotype. These type of connective tissue diseases are labeled as undifferentiated connective tissue disease. And whereas there is another cluster of patients where they exhibit features of SLE or polymyositis or Sjogren's, where there is an overlap. These kind of patients are commonly clubbed under mixed connective tissue disease. And there are two criteria, that is the Alarcon-Segovia's criteria for mixed connective tissue disease, where with the clinical symptoms of swollen hands, synovitis, myositis, and Raynaud's phenomenon, but there should be a quantitative anti-RNA antibodies present with a titer of more than 1:1600. At the same time, with the Kranz criteria, with these clinical features of synovitis and myositis, there should be an anti-RNP antibodies with a titer of 1:1200 present. Only then it can be diagnosed as mixed connective tissue disease. And coming to about inflammatory myopathies, there can be polymyositis or dermatomyositis where there is the presence of anti-Jo autoantibody pointing towards polymyositis. There is also another very new autoantibody present, that is anti-HMG-CR, that is coenzyme A reductase, with an increased serum concentration of creatinine kinase, then it may point towards the diagnosis of inflammatory myopathies. Now, coming to which lab test should be used in these SARDs patients. So ANA serves as the serologic evidence of CTD, where the ANA patterns reflect the target antigens and the possible disease association. Then comes the ANA, once that is positive, we have to go for the ANA subsets, which should be ordered in patients who are positive for ANA. And then other investigations to assess the organ involvement are the CBC, the urine analysis for protein, the sediments and cast, liver function test, creatinine level, complement C3 and C4, HRCT for complications of MCTD, which is interstitial lung disease. Then we can go for echocardiography and kidney biopsy, nail fold capillary capillaroscopy, and minor salivary gland biopsy. Now, what are the indications of this kidney biopsy mainly seen in lupus nephritis? Suppose if there is a proteinuria of more than 500 milligram per day present, if there is an active RBC sediment of 5 minimum RBCs per high power field present, or if the creatinine level is more than 1.3 milligram per DL, or there is a change in a class transformation, then the kidney biopsy is indicated in these patients. So coming to the ANA, the gold standard, as we know, there are many methods how we can identify, we can detect ANA, but indirect immunofluorescence being the gold standard, with a minimum titer dilution of starting with 1:80 or 1:100 according to the kit. If ANA evaluation is in a negative immunoassay, that is with ELISA or with any other platform, it is negative, but if it is positive for IFA, then the reported ANA pattern along with the titer, along with the patient's clinical history and presentation, is useful for the subsequent autoantibody to be performed and for disease, ultimately for disease confirmation. But if ANA evaluation is positive in immunoassay but negative in IFA, then the predictive value of these systemic autoimmune rheumatic disease is generally low. So these are some of the autoantibodies with their clinical associations and the specific, with the specific connective tissue disease, like anti-CCP present with rheumatoid arthritis, dsDNA with SLE, anti-Smith with SLE, ribosomal P protein with SLE, SSB-LA with Sjogren's, SSA, RO52 and 60 with Sjogren, SLE, RNP with MCTD, topoisomerase with systemic sclerosis, JO1 or histidinal-T RNA synthetase with polymyositis, and centromere B with limited cutaneous form of systemic sclerosis. Now, these are some of the IFA-ANA sensitivity in different diseases, with MCTD being the highest. But in normal, we should not forget that in normal adults also, less than 60 years old, there are patients who are positive at 1:80 dilution or more. But if the dilution we start at 1:40, there also you can get a few cases leading somewhere with 7 to 35%, where the normal patient will also give a positive ANA. So the recommendations for the rational algorithm that I have already said, that we have to use the IFA HEP2 cell line, now more a cell line transfected with the complementary DNA, that is HEP2000 is being used, and HEP2010 have also come, where there is overexpression of the SSA and Rho antigen. So the ANA titer screening test with a titer of 1:160 is clinically relevant, and there should be a complete evaluation of ANA with screening, and the specificity confirmation is actually recommended. So as I have already said, why 1:80 or 1:100? Because according to the CLSI guidelines, that 95% of the patients, normal population, should have ANA negative at this cutoff. So 1:80 or 1:100 is used, and a titer of 1:160 or more, and up to an N titer dilution of 1:640 is usually clinically very relevant, and anti-dsDNA has to be determined with a quantitative assay, or we can use Critidia lucili immunofluorescence test, that is optional, but nowadays it is recommended that whenever we get an ANA positive and the pattern is homogeneous or speckled, or we know the clinical symptoms are in lieu with SLE, we should go for an anti-dsDNA determination. So IF pattern should be reported along with the titer, along with the corresponding AC number. This is very, very important. AC number is anti-cellular number, where all the patterns by the ICAP has been given some numbers. So in negative is AC0, AC1 is homogeneous, AC2 is DFS positive, AC3 is centromere, AC8, 9, 10 is nucleolar, and so on. The list goes so on. Then the specification of the method used for the ANA-specific antibodies, that is either ENA or dsDNA. ENA can be, that is extracellular nuclear antigen. It can be done by the line immunoblot assay, or it can be done by the ELISA or immunoassay CLIA method, that is more accurate. So that should be the part of the report. Now, quantification of the ENA, that is actually mandatory only for the determination of MCTD, because UNRNP with the titer of, I've already said the two criteria where 1 is to more than 1600 or 1 is to 1200 is important for the diagnosis of mixed connective tissue disorder. And when we see there is interference in the assay, then it is advised to do a serial dilution of the sample and repeat the assay. So now repeat determination of ANA actually is not advised, but it is advised only in initially negative or low titer positive patients, only in case of persistent or worsening clinical symptoms. So the clinical symptoms is very, very important and pertinent for the diagnosis of connective tissue disorder, along with the specific ANA and the autoantibodies present. And in the patient with clinically defined CTD, there is actually where there is a clinical shift in mixed connective tissues, there is always an overlap, but this overlap syndrome, they trend to go towards a diagnosis of a conclusive, definite CTD. So when there is a clinical shift of these kind of case patients, then we can repeat the ANA. Repeat determination of positive dsDNA is present in, it can be done when there is an inactive disease for 6 to 12 months, or when there is a, like in lupus nephritis, where there is in 2 to 4 months to assess the disease activity. So that time dsDNA is repeatedly determined. And repeat determination of ENA can be done in negative ANA patients where previously there was negative, but there are again clinical symptoms where we can go for the SSA, row 52 and SSB. So that can be done. And if there is, again, there is a clinical picture, clinical shift in MCTD cases. So these are actually the HEP2 cell patterns, negative, nuclear, cytoplasmic, and mitotic. Anything which we see under the microscope will have relevance, might not have relevance, but sometimes we tend to neglect some of the clinical features with a very high fluorescence under the microscope, especially the cytoplasmic. We should not do away with the cytoplasmic 18, 19, and 20, which relates to the SLE. So cytoplasmic's fine speckle, which corresponds to AC number 19 and 20, should be given in the report. And the nuclear pattern, these are very common, the homogeneous, speckle, centromere, and the nuclear being very much connected with the CTD. Now, what the reports communicate? First, positive, it should be positive or negative. When it is positive, first we should give the pattern along with the ICAP code, that is the AC number. Then the titer, that is very, very important. We should give the first starting dilution either as 1:80 or 1:100, and then go on giving the end titer. The end titer is very important with the remarks. Now, coming down to ANA reflex testing, it improves the diagnostic of the connective tissue disorder. So this is the two process of the ANA profile. Now it is ANA, it should not be taken as a confirmatory test. It is always a screening test. Then it should be confirmed with dsDNA if there are clinical features of SLE present. And then subsequently we should do the ENA. ENA can be done by line blot assay or solid phase immunoassays. And these are the two steps tier, which I have already said, where the ANA being positive, then dsDNA, Smith and ribosomal P very consistent with SLE, SSA, Rho, SSB, La very consistent with Sjogren's, RNP very consistent with MCTD, and SCL and RNA3 systemic sclerosis, and Jo1 antibody with polymyositis. So if there is more than one pattern observed in the immunofluorescence where there is mixed pattern, then we should go for the reflex testing, that is ENA has to be done. If the cytoplasmic pattern is positive, that is AC19 is positive, Subsequently, we should go for the ribosomal P protein antibody, and if that is also, then if negative, then we should go for the polymyositis panel, and if the speckle pattern is detected but reflex ANA is negative, we should always go for the dermatomyositis autoantibody extended panel. So these are the same thing. So suppose ANA, when there is a high clinical suspicion, then we order the ANA, and these are the most common patterns positive with the associated specific disease and the specific antibodies. These are some of the clinical picture which we get. I will not go into details of this. Cytoplasmic, I have already said. And antibodies to extractable nuclear antigens are detectable in a considerable number of sera that test negative for anti-nuclear antibodies. Just previously, we were listening to the discussion where Sir has said that the ANA can be negative. So, but when we do the ENA, if RO 52 or 60 is positive, then it comes to a pertinent diagnosis of STD. Now, this is the main guideline which shows that where there is high clinical suspicion of connective tissue disease, we have to ask for an ANA testing, preferably by IF. If it is positive, then we evaluate the history with the clinical findings and degree of ANA positivity with the pattern recognition. We go, it is SLE, then we go for anti-DS, DNA, anti-Smith. If it is positive, SLE likely. If it is negative, we have to look for other diagnosis and follow-up. If it is not, it is a speckle pattern, we go for a primary Sjogren. It could be SSA, SSB, positive Sjogren syndrome likely. If it is negative, you have to go for a follow-up and other diagnosis. If it is centromere and with a CE and PB positive, then it is diagnosis is limited cutaneous systemic sclerosis. If it is nuclear pattern AC 8, 9 or 10, then it is likely to be systemic sclerosis with SCL 70 positive, it confirms systemic sclerosis. And if it is others where there is, the pattern is not very recognizable, or it could be nuclear or speckle, where we get a positive, where UN RNP, it points towards MCTD. Anti-U3 RNP, it points towards scleroderma. If it is JO1, it confirms myositis. And if it is negative, we have to look for other diagnosis. And when sometimes ANA is positive, but ENA, dsDNA, everything is negative, we have to think for other possible diagnoses like autoimmune liver disease, thyroid disease, chronic hepatitis C infection, recent viral infection, or elderly female. And if it is negative, then we have to do the repeat ANA after some times. But if then also it is negative, we go for SSA. If we doubt it is positive, then it is ANA negative variant, SLE present. And if it is negative, then we have to follow up and do the clinical follow-up again. So this is in short about the diagnostic algorithm of connective tissue disease. Now, assessing the disease activity in connective tissue, it should be done through thorough clinical examination, and these are the things: C3 level, C4 antiphospholipid platelet count, TC, TLC, ESR, and CRP has to be done. Now, coming to a case, this is a very interesting case where we got a mixed pattern with only primary intensity of 1+ at a primary dilution of 1:100, which points towards a cytoplasmic febrillar midfilamentous AC16 and a mid-body AC27. We always tend to give a negative report for this type of things, but when we did the dsDNA, it was negative. Following, when we did the ENA profile, you see here, Smith antibody is positive, which is consistent with SLE. Anti-UN RNP is positive, which is very much consistent with mixed connective tissue disease. Then even ribosomal P protein is strongly positive, which is consistent with SLE. So like this, we have come to a conclusive diagnosis, because so the clinician should always write the history, and we should always not leave it ANA negative or ANA positive 1+. The pattern is this, so we should not give a negative report. So we should do all the tests, dsDNA and the ENA profile, to come to a conclusive diagnosis when there is a very high clinical suspicion. This is a very clear-cut case where there is a mixed pattern of AC1, which correlates to nuclear homogeneous, and cytoplasmic also is present. That's a mixed pattern. And the N titer was 1:320, but on doing the dsDNA by cleft IF, then that also showed a positive 2+ with N titer of 1:320. And it also showed UN RNP, but very mildly positive. This is also a mixed pattern where the N titer is very high, 1:3,200, with AC1 and AC19, which is consistent with SLE because dsDNA is very positive. And this is another strong case where there is AC1, 4 and 5, that is homogeneous and speckled pattern, both are present with dsDNA being positive, so very much consistent with SLE. And this is the case where I got an intensity of only 2 plus, N titer is 1:320 with speckled pattern. And when we did the immunoblot in this LIA, we found that it is row 52 was present. So row positive 52, only row 52 present is always consistent with inflammatory myositis, that is polymyositis. You can see the JO1 also is slightly positive. It's not positive, it's just 1, but maybe in the following scenario when it becomes very intense, then it will become positive. But row 60 is only when there is row 60 it is present, then we have to go to the conclusive diagnosis with the clinical symptoms that it is way with SLE. But when row 50 and 52 and 60 both are present, then it is Sjogren's syndrome. So to conclude, IF is the gold standard test, and ANA profile has to be done. dsDNA is the best diagnosis for SLE and disease monitoring. ANA titers may not be helpful in follow-up, hence repeat of ANA is not recommended. A positive ANA does not mean connective tissue disease, and a negative ANA does not exclude connective tissue disease. So ANA, dsDNA remains the first screen to be followed by ANA profile, and collective diagnosis of connective tissue disorder